Good afternoon. Good afternoon. It's 12:30 here on the East Coast. For some of you, it may be earlier, and for some of you, it may be later. So, welcome. This is Dr. Velma Scanterbury. I'm the medical consultant for Dialysis Patient Citizens Educational Center. And thank you, Yolanda, for joining us this afternoon. I hope you're having a beautiful day as the weather is now moving into the chilly form of fall. And so I hope you guys have pulled out your sweaters and all those warm garments that you need to have your coats ready, as some of us will be dipping into freezing. So if you haven't brought those plants in, please do, or expect them to suffer a little bit over this upcoming freeze. It's beautiful this time of year, and I hope you are either able to take a walk. It's kind of windy outside in most areas, but at least enjoy the seasons and the change of colors, which are beautiful. This is a beautiful time of year, and thank you all for joining. I'm Dr. Scatterberry, medical consultant for Dialysis Patient Citizens Educational Center. And I hope each and all of you are doing well as we now move into the month of November. And so we're into a new month as this year is very quickly moving on. So if you have any questions, as we usually try to answer your questions here on this Instagram Live, please put your questions in the chat. Let me know what you would like to talk about. And one of the things that becomes important in terms of if you're on dialysis, wanted to know about getting on the transplant list. Why have you not gotten a call from the transplant center? I've been on the list for 5 years and I haven't been called. I've been on the list for 8 years and I haven't been called. Or I just got I got my kidney transplant and I've been doing well. Or my kidney is failing and I need another kidney. What's the best way to transition back to the list when you when your kidney continues to do poorly? And it becomes important that knowing that when you get when you need to get retransplanted, that's going to start the clock all over again. So any time that you have with your first kidney is not going to apply unless you lost that kidney within 6 months of your transplant. And so if you had that kidney for a year, you're going to start all over again with new waiting time. So if that kidney isn't working right, you want to know what you need to do to get back on the list, even if you may not be transplanted, but you want to get that clock starting to say, I am back on the list. I may not need to be transplanted, but I want to start gaining time. And so that if I can really drag out the time with that kidney as it continues to fail, the more you can do that, the more you can avoid dialysis prior to receiving that retransplantation. So question was asked, how long should a patient be on dialysis wait to go into the transplant list? Actually, you do not have to be on dialysis to get on the transplant list. Once your estimated glomerular filtration rate, or your EGFR, gets to a documented 20% or lower, you can be listed for transplant. You may not be ready to be transplanted, but you can gain time. And for many of the patients who are not on dialysis, because the clock starts to tick once you hit dialysis, and you can gain all that time once you get on the list. Let's say you've been on dialysis 5 years, and you're now coming for transplant, you will gain that 5 years on the transplant wait list when you jump on the wait list, even though you've been on dialysis 5 years. But if you're not on dialysis and you're stage 5 kidney disease, and you want to get on the waiting list, you can be on the waiting list as long as your nephrologist can find a creatinine and a glomerular filtration rate of 20% or less. Even if it increases subsequently and you continue to do well, that's enough to get you on the list. And your time can begin to accumulate even though you're not on dialysis. So that's an important key, because while you're not on dialysis, you can only accumulate time if you get pre-listed prior to dialysis. Remember, getting listed doesn't mean you're ready to be transplanted. You can be on the wait list and be inactive if you continue to do well, so that you can gain time prior to going on dialysis, and you can be monitored. And for some patients, if the perfect kidney comes along, and you may not be ready for a transplant, your nephrologist may say this is too good to pass up, and so that is an option that you need to consider, getting on the waiting list prior to getting on dialysis. Many people feel like, I gotta wait. No, you don't. Tell your doctor, even though I'm not on dialysis, I want to get on the waiting list before I get there. Is skin cancer common for transplant and our dialysis patients? And that's one of the things that we want to screen patients after transplant, because it is one of the most common cancers that are manifested in transplant patients. While the other cancers such as breast or colon do not show any difference when you compare the transplant population to the non-transplant population in terms of incidences of other cancers, skin cancers do have a higher incidence within transplanted patients because of immunosuppression. So one of the things we do is we make sure that we send our patients to dermatologists, and they should be seen annually. The whole skin should be inspected so that we are monitoring and making sure that you're not at risk or have cancers that need to be treated. And these are generally the most commonly exposed areas for many patients. It's on the nose, the ears, and the head if they're often bald, and around their mouth, or even on their shoulders, and sometimes other places on the forehead. Sometimes it's on the hands and arms. And so it's important to monitor patients. And so one of the criteria after transplant is that you return to your primary care physician, and that you continue with your cancer screening. So while you get your colonoscopy and your mammogram, your prostate check if you're a man, everyone should get their skin checked and see a dermatologist to really go over your entire body to make sure you're not at risk for cancers. And there's some people who feel like, I'm an African American, I probably wouldn't get skin cancer because I'm dark skinned. That does not matter. Everyone needs to be screened for skin cancers because it's much more common, and your skin becomes a little bit thinner and more fragile as we get older, and also due to the immunosuppression, that especially the steroids post-transplant, that puts us all at risk for our immune system to not work as well. And so our immune system is dampened by the anti-rejection medicine. So our bodies are not able to mount a response to protect us as much as we would normally if we didn't have these anti-rejection medicines on board. So that's very important for those of you who are post-transplant and have not had your skin checked. Make sure, especially if you're fair-skinned and blonde, that you really get checked for skin cancer. So thank you very much for that question. Another question is about parathyroid, what it is. Well, your parathyroids are glands that sit above and below your thyroid in your neck. And your parathyroid glands secrete a hormone, parathyroid hormone. Generally, this hormone really controls your calcium phosphorus metabolism and its balance. So so one of the things it does is really to make sure that you have enough calcium in your system, and that you're taking enough calcium. And so when your parathyroid senses that things are out of whack, it begins to secrete more parathyroid hormone that stimulates your body to keep that calcium phosphorus in balance. Unfortunately, we have what's called primary hyperparathyroidism when it's overactive, secondary and tertiary. So primary is generally when your parathyroid gland just starts to put out more than it's need to, and oftentimes it's most commonly an adenoma. So you have 4 glands, and oftentimes one can develop a little adenoma, which is sort of the cells decide to hypertrophy and have their own activity ongoing, and that can cause more secretion, which leads to higher calcium and bone damage. And so for primary, you find the cause, you take it out, and it goes away. And then secondary could be due to stimulation from, say, renal failure. Your calcium levels are low, and so you need more calcium, and so your thyroid starts to make more PTH hormone. And tertiary is when it goes out of control. It's no longer working in sync with the body. It's making too much, regardless of the fact that you have regulated your calcium and now your phosphorus, all those things. And so now it's turned on and it's unable to turn off. And that causes much more PTH to be put out. And when your parathyroid hormone gets too high, it can stimulate imbalances in your calcium phosphorus metabolism. And now you have to control that with Sensipar. And what that can lead to is bone damage, brittle bones, because it's wearing, it's constantly causing the body to do things that is not necessary, and you then have to control that. Sometimes the medications doesn't control it, and when it gets out, it means that all 4 glands are just working, they're turned on, and something in the body can't turn it off. So what happens is you go in and you take out 3.5 glands, or you implant a small piece in your arm so that when it continues to enlarge, you can go back and reduce it because it's now not able to turn it off. So your parathyroids for many patients on dialysis becomes a problem. They all are working over time, cannot be turned off. You have to remove 3.5 glands. Some surgeons will leave the remaining piece in the neck so they can go back if it's still high to remove it. Other surgeons will put it in the arm, so that it in the muscle in your hand, so that when your parathyroid hormone, if it gets controlled but it continues to be higher than normal, they can go back and perform surgery more easily in your arm than going back into your neck. So you have to make sure a lot of that is made worse when you get your phosphorus levels too high. And so you want your calcium phosphorus goes in balance. So you want to definitely control your phosphorus so that can be better in terms of controlling the amount of calcium and not causing your parathyroids to go out of whack. Transplant drugs, brand versus generic. Please explain the difference and how it can affect the transplant kidney. Very good question. Unfortunately, initially when we start out post-transplant, we use generic because generics are generally, the brand name, because the brand is first made and then once the patent runs out, the drug is allowed to have generics out there, which are similar to the original brand name drug. But to be a generic, you just have to be within 20% plus or minus the potency of the original brand name. So for many patients, many insurances will only cover a certain number of brand name drugs. And if you have too many brand name drugs, your insurance will not cover for you to get that drug because you've run out of the number. Let's say you only allow 4 brand name, and there's things that may not have generics. Say, for instance, if you're on Plavix, there's no generic for Plavix, so you have to be on that brand, that you have to be on that particular medication. Well, for transplant drugs, generally immediately after transplant, we use brand name. And as you get further out, generally the insurance will dictate that you have to switch over to a generic. And when we switch over to generic, oftentimes different pharmacies will have contracts with different pharmaceutical companies depending on who is giving them the best bid for the drug. So for many patients, when you switch to a generic, we tell the patient, make sure you stay with that generic, because that generic, depending on its potency, if it's much closely matched to the brand name or whether it's further away from the brand name, we want to be able to measure your levels once you switch to a generic to make sure they're consistent with what the brand name has been. So unfortunately, some patients will get different generics from time to time. So oftentimes the pharmacist, we will say, please stick to the same generic so that once we are able to see that your levels are on par, let's say you switch from the brand name to the generic and your drug levels are too low, we're going to raise that generic dose because the potency may not be as strong. And that becomes important. And so especially for immunosuppressive drugs, sticking with the same generic so that we can see whether the potency of that medication is close to or comparable to the brand name that you were taking before. So that becomes something to remember, because unfortunately with many insurances, they demand that you switch to the generic. Oftentimes, if we see that there's variability in your levels with the generic, then we would put brand name necessary, and the pharmacist may have to do a prior authorization to make sure that your pharmacy gives you that particular brand name over and over again. But it will constantly be questioned by your insurance, who do not want to pay for the higher cost of the brand name drug, especially when there's cheaper medication out there. But the bioavailability of that medication is important, and the amount of drug that's in your system comparable to the brand name. So remember that if your pills from your pharmacy are not consistently the same, depending on the generic form that you're using, please talk to your pharmacy to find out if they can be more consistent in using the same generic drug, especially since you're that customer who is going to that using that pharmacy over and over again. So thank you so much for that question. Great question. When you change generics, remember each generic has a different potency, and it's important to let your transplant coordinator know that you switch to another, so that if your levels are labile and they see a different change in your drug levels, it may be due to the change in your drug, the form that you're using. So those things become important. They may ask you to repeat your drug levels to see over time if they sort of level out to something that is within range and not really putting you at risk for rejection, because your coordinator may say, I see, perhaps he's not taking his medication as he was because now the levels are lower, or now the levels are higher than they were because the generic now has greater potency compared to your brand name. So just thank you for that question, Nancy. And another question is mag oxide. This is one of the things I realized for some of our patients. Mag oxide, if you go to the pharmacy to pick up magnesium oxide, which is one of the essential elements that is needed, that gets excreted, especially with patients on tacrolimus for immunosuppression. And so for many patients who are on tacrolimus, they will have a deficit in magnesium. And so they have to take supplements, and there are very many different forms of magnesium. Some people will say, if I pick up a certain brand, I'm good with it, but if I use those dark colored pills, I know it's going to give me loose stools. So magnesium really contributes to GI disturbances for some patients, and if you're constipated, this may be a good thing, but if you're not, it can really cause diarrhea and loose stools. And if you're on magnesium plus mycophenolate for immunosuppression, the combination can often make your loose stools worse. So for many patients, I usually advise try not to take the two together, because they may make you really play havoc on your GI tract. But for others, it may not make a difference. So that's the major side effect, is often some GI upset, some abdominal cramping, and stomach ache for some patients. But for the majority of patients, they're able to tolerate it well. Find a brand that works for you and doesn't cause loose stools. And once you find that brand, stick to that brand. and it will work for you over time. So thank you so much for that question. It's just one of those things that we have to be careful of, because for many patients, even years after transplant, they're still needing to have magnesium replacement. And that's just a function of the tacrolimus. We don't see it as much with cyclosporin and those patients who are not on tacrolimus. So it's unfortunately, for some, it's needed. So thank you all for joining. Again, I'm Dr. Scanterbury, and I am the medical consultant for Dialysis Patient Citizens Educational Center. I'm here to answer your questions about getting on the transplant list. Why am I waiting so long? We had a question earlier about getting on the list when before you get on dialysis, which allows you to gain time when you're not ready to be transplanted. And for many patients, they can sit on the list. Oftentimes they get to an eGFR of 18%. They can be listed, but they're feeling fine. They don't have major problems with their blood pressure. The potassium is well controlled. They're not short of breath or gaining any fluid in their legs. And they're not terribly fatigued. So in that situation, we would say, okay, I know your eGFR is less than 20%. As many of these patients who continue to work either part-time or full-time and are able to carry out the activities of daily living without needing to say, I'm ready for a transplant. Because you want to make sure that that person that when you give them a transplant, you're improving the quality of life and you're improving their longevity. So if they're not symptomatic at that point, they may not be ready to get a transplant, but they can gain time. Then there are those who wait many years and don't get called. And we know that there are patients who have antibodies or have a previous transplant, and now it's much more difficult to match for a kidney. And so you may get called, your name may come up for a transplant, but when we do that cross match to look at to test your blood against the cells of the donor, we find that you react, and yet you're destroying those cells of the donor, meaning that you have antibodies in your system that's going to fight that particular donor. And for patients who've had multiple transfusions, which is one of the reasons why we tell patients, if you're on the list for dialysis or for a transplant, you want to make sure that if you need a blood transfusion, that you let them know you're on the list, as most places will make sure that they use a special filter that captures all the other cells other than your red blood cells, such as your dendritic cells, and macrophages and other cells that cause your immune system to develop antibodies that go along with your red cells and trying to hitch a ride into your system, and those cause antibodies. And so you become sensitized, which means it makes it more difficult to get transplanted because these antibodies are already in your system playing havoc and preventing you from getting a transplant that would work successfully. So many of those patients we test over and over again, and they get special points, more points, so that they can have a little bit of priority over some of the patients who don't have antibodies, so that they can have their blood tested to many more donors because of their likelihood that they'll have reactivity. And so that's important to know. If you're waiting long, more than you feel like you may want to talk to your coordinator to figure out, why have I not gotten called? You want to make sure that you are active and not inactive, and you're thinking you're actively waiting on the list when in fact you may be inactive because something is pending and you didn't realize that that was needed. So have that discussion with your transplant coordinator so that you make sure that you're up to date with all the tests that are needed to keep you ready and able to be called in when you get transplanted. You want to make sure that you keep up to date, because oftentimes we call patients and they tell me, well, I just had bypass surgery, or I have an infection in my leg, and so we're not able to proceed with that transplant because you have something that's going to prevent you from having that successful surgery. So those are things to make sure that you are definitely communicating with your transplant center that you're up to date with all your health maintenance, that you're up to date with your cardiology, getting that heart test, that you have done all your colon cancer screens. One of the things you want to make sure is if you have a need for a cardiologist or underlying heart disease, that you keep up to date with that echocardiogram or stress test, whatever may be that's needed to keep you healthy and ready to be transplanted. For many patients on dialysis, we want to make sure that they're compliant and that they're not in fluid overload. So you want to be able to control your intake when you're on dialysis. Oftentimes you have a long weekend or it's a holiday and you have an extra day. You want to limit that amount of fluid. So your dialysis unit is telling you, especially if you have no urine output, then the amount of intake, unless you're going to burn it off, have to come off in that dialysis treatment. So you want to not exceed your expected fluid gain, because that puts more work on your heart. And when you put more work on your heart, you contribute to underlying heart disease, because now your heart's struggling, trying to work with that extra 10 pounds that you gained. So now that the summer is over and you may not be hot and burning up, you may have better options for controlling your fluid intake. Look at how much you're taking in. Look at even things like soups count. If you're eating fruits that are high in water content, like watermelon, you have to realize that counts also. So you have to look at your overall gain. So if you're gaining more, then you're going to have to take off more. And so when you take off more on dialysis, you leave yourself open to more cramping and hypotension. Now your blood pressure is dropping because you came in with an extra 10 or 12 pounds that you weren't supposed to gain, and the dialysis is trying to take that off so that you can not leave with extra weight on, knowing that it becomes harder with each dialysis treatment to take it off. So your gains are going to be proportionate to what needs to be taken off, and so you need to figure out, how can I control this by limiting my intake, by exercising to try to sweat some of it out if you can. But if you don't have urine output, it becomes more difficult. And this is where having more dialysis treatments can be beneficial. And so if you're on home dialysis, you can take that off a lot easier. If you're on dialysis more than 3 times a week, you can, whether you're in center, whether you're home dialysis or night dialysis, that leads to better functionability of your body and able to deal with that extra fluids, because you're taking it off on a daily basis as opposed to waiting 2 or 3 days to take that fluid off. Underlying heart disease is the main cause of death for patients with kidney disease, as well as for patients who come to transplant with which is the major cause of death, even for transplant patients that are related to time on dialysis. So the minimum amount of time you have on dialysis, many of those patients do better because they're not subjected to the same underlying heart stresses as hemodialysis that hemodialysis places on patients who've been on dialysis for a long time. So is it possible to eat too much protein as a transplant patient? It is possible to consume too much protein, absolutely. I've had a patient who unfortunately got a living donor, and he was a bodybuilder. And we told him after transplant, you really can't not take this high protein and high creatinine to build muscles like you were pre-transplant. And that protein too much protein, especially when you're only have a single kidney, is going to make that kidney work harder, and so you will start beginning to excrete more and more protein, which can act as a sieve that leads to progressive proteinuria. So you don't want to be having a high protein bodybuilding regimen to build muscle, or just because you are taking some special diets. You want to be careful so you don't exceed what your body needs, because that's going to be reflected on the work that your kidney have to do to excrete, to really manage that protein in your body. So what you need is what you need, and talk to your transplant coordinator about that. So this has been a good conversation. I thank you all for joining. I appreciate you being here, and it's now 1:00. Thank you. Have a great day, and remember to stay healthy. Look out for others. Help all those who may need help that is around you, and get your flu shot and your COVID shot, your pneumonia shot, and stay healthy. God bless. Have a great day.